Thank you for the introduction, Dr. Mundis. So as he said, I'll be talking about adult spinal deformity, indications, and treatment. So in this talk, we'll cover the background of adult deformity, including the etiology and symptoms, as well as the natural history and the progression of adult spinal deformity. We'll review the commonly measured radiographic parameters and discuss pertinent physical exam findings, and then we'll discuss the indications for non-operative and operative managements. And then lastly, we'll review the current surgical techniques used in adult deformity correction. So how common is adult deformity? So this was initially thought to be a relatively uncommon disorder. The initial studies were done on younger patients and didn't take into account older patients with degenerative changes. We now know that adult scoliosis is more common than we initially thought. This was one study that looked at DEXA scan imaging of over 3,000 patients over the age of 40, and using the parameter of a coronal Cobb angle greater than 10 degrees, they found an overall prevalence of 8.85% of scoliosis in their patients over the age of 40 years old. They did find an association with age and race, as we expect as age goes up. The prevalence goes up to about 50% in asymptomatic patients that are greater than 90 years old. Early investigations on the clinical outcomes related to adult spinal deformity suggested that this wasn't a major problem for these patients. This was a JAMA study published in the early 2000s that basically concluded that untreated idiopathic scoliosis caused little physical impairment other than some mild back pain and cosmetic concerns. Patients at 50-year follow-up were said to be, quote, productive and function at a higher level. However, one major problem with this study was that they did not evaluate the sagittal plane parameters, and we now know that patients with significant sagittal malalignment and combined deformities report pretty significant disability. A more recent study published in 2016 compared about 500 patients with symptomatic adult spinal deformity to the general US population. They found that the mean SF36 scores for these patients was significantly lower than the general population, and that this disability increased with age and at a faster rate than the general population. The mean SF36 values were similar to those reported by patients with diabetes, heart disease, and rheumatoid arthritis. And in the severe forms of adult spinal deformity, report similar physical limitation and health impact as patients with limited use of their arms and legs. And so clearly this study sort of demonstrated that this has the potential to have a greater impact on patient function than what was originally suggested in that previous paper. So adult spinal deformity is essentially an umbrella term to describe the different etiologies of scoliosis in the adult patient. A common cause in adults is a history of adolescent idiopathic scoliosis that was untreated and then subsequently progressed. The most common form, however, is this degenerative or de novo scoliosis. These patients typically don't have symptoms before the age of 40, and their deformity is a result of degenerative changes to the spine, including disc degeneration and facet arthropathy. Some less frequently etiologies of adult spinal deformity are iatrogenic deformity, which is a deformity that arises after a prior destabilizing procedure, and then a primary sagittal deformity, which may be degenerative or iatrogenic in nature. So in degenerative scoliosis, the typical pathway begins with disc degeneration, facet arthropathy, ligamentum hypertrophy, and this ultimately leads to segmental instability with spondylolisthesis and rotational deformity, and oftentimes there's resultant canal or foraminal stenosis. So the four primary planes of deformity include the coronal, sagittal, rotational, and translated planes. And an important concept in this idea is the cone of economy. Normally when patients assume the erect posture, they stand with a certain zone of balance in which their torso remains within a certain distance from their pelvis. By doing this, energy expended by postural muscles is minimized. Now, when there are degenerative changes to the spine, this results in loss of lumbar lordosis and forward sagittal imbalance, which then pushes the patient out of this zone. And then beyond this zone of economy, the energy expenditure rapidly increases, and eventually spinal malalignment can result. And this oftentimes necessitates external supports such as canes and walkers. So what about the risk of progression? So the risk of curve progression depends on several things, including the curve type and the curve magnitude. So patients with untreated idiopathic scoliosis have a variable rate of curve progression. Patients with more mild curves, less than 30 degrees, rarely progress. However, curves of greater magnitude, such as greater than 50 degrees, commonly progress at a faster rate. It's been shown that patients with degenerative scoliosis tend to progress at a faster rate, with studies suggesting a rate of 3 to 5 degrees per year for the degenerative scoliosis type. Progression also depends on the location of the curve, with thoracic curves progressing the fastest at 1 degree per year, and lumbar and thoracolumbar curves progressing a little bit slower. And it's been shown that there's increased risk of curve progression when the intercrestal line falls below L4, L5, or if there's pre-existing rotational changes about the spine. So sagittal balance. So the sagittal plane deformity is an important consideration when assessing these patients. The SVA is a common measurement that we refer to, and this is defined as the horizontal offset between C7 plumb line and the posterior superior aspect of the S1 vertebral body. Spinopelvic inclination is a global angular measurement of sagittal alignment. It is formed by a line from the femoral heads to T1 or T9 centroid and the vertical plumb line. Now, since this is an angular measurement rather than a length measurement, it's not subject to the same magnification variability that may be present on radiographs. Additionally, the spinal pelvic inclination has been shown to be more accurately correlated with the quality of life scores compared to the SVA alone. Sagittal balance overall results from a combination of lumbar lordosis, thoracic kyphosis, and pelvic incidence. So how important is sagittal balance? So this was a 2005 study by Glassman et al. That found that the severity of sagittal malalignment directly correlated with both quality of life and the degree of axial back pain. As sagittal balance increased, the mean ODI scores increased and the SF12 scores decreased in a linear fashion, as you can see there. They also found that thoracolumbar and lumbar curves generated less favorable scores than thoracic curves. They reported that kyphosis was better tolerated in the upper thoracic spine, however, was poorly tolerated in the lumbar spine. A similar study by Glassman et al. Found that positive sagittal balance was the most reliable predictor of clinical symptoms. Patients with positive sagittal balance reported worse pain, function, and self-image. So clearly this is the parameter that we sort of focus on most. Not to ignore the coronal plane, but in the coronal plane, we do measure the C7 plumb line and the CSVL, which is the vertical line that passes through the center of the sacrum. And of course, the Cobb angle measurement, measuring curve magnitude. Spinal pelvic parameters kind of include this slide just for me, just to review, because I have to review this pretty much every time I look at it. But these are the three main spinal pelvic parameters that we typically focus on: pelvic incidence, pelvic tilt, and sacral slope. Recent data have shown that failure to account for pelvic alignment when treating spinal deformity does increase the risk of residual deformity and treatment failure. So these are parameters that we should always look at. It's been shown that increased pelvic tilt values reflects a pelvic retroversion and correlated with worsening quality of life scores. So it's been recommended that pelvic tilt should be restored to less than 20 degrees in spinal alignment procedures. Additionally, lumbar lordosis should be within 9 degrees of the pelvic incidence. So how do patients typically present? The most common complaint, as we would imagine, is axial back pain, which occurs up to 90% of patients. This could be a result of paraspinal muscle fatigue. Interestingly, when there's spinal stenosis, the pain is not relieved by leaning forward. Patient improvement with leaning forward usually indicates spinal stenosis and neurogenic claudication. Patients, especially with degenerative scoliosis, present with more radicular symptoms like leg pain and weakness. However, acute neurologic deterioration is rare in these patients. So on exam, when we see these patients in clinics, it's always important to disrobe the patient to allow for inspection of the full C-spine. We look at their standing position, we look at their coronal and sagittal balance, and their ability to bend laterally and forward. And we look at compensation methods, which include the pelvic retroversion and hip and knee flexion. So in sagittal deformity, we're looking for hyperkyphosis, which oftentimes is seen in the thoracic spine. We look for flat back or a chin to chest deformity. In the coronal plane, we're looking for shoulder or hip asymmetry. Oftentimes, the patients will have an antalgic gait, maybe a Trendelenburg gait. They'll be unsteady, slow. And then, of course, always important to have a complete neurologic exam, a hip exam, and a knee exam, and get a accurate peripheral vascular exam. So part of our radiographic evaluation, as we've seen in our case report, or in our case reviews, full-length standing AP and lateral radiographs are imperative in these patients. Oftentimes, flexion, extension, and lateral bend radiographs will be used to assess the flexibility of the curve and rule out any instability. And CT, advanced imaging, including CT scan, SPECT CT, MRI, which is especially useful when radiculopathy is present. These are pretty critical parts of our workup and help with operative planning. So no strict indications. So non-surgical management, there's no real strict indications for this. In general, patient typically needs to have no significant stenotic, radicular, or back pain symptoms. Generally, the curves need to be less than 30 degrees, less than 2 millimeters of subluxation, and quote unquote reasonable sagittal and coronal balance, as reported by Silva and Lenke. Our surgical or non-surgical management strategies include physical therapy, analgesics, NSAIDs, neuroleptics. Aggressive treatment of their osteoporosis is always very important. Optimizing their nutrition, smoking cessation if they're a smoker, injections, especially if there's a history of radiculopathy. Bracing oftentimes doesn't really help prevent the progression of deformity and is also pretty poorly tolerated by the patients. This was a systematic literature review of non-surgical treatment in adult scoliosis, and basically they found that conservative care may be a helpful option, but evidence is lacking in this area, and there's no real specific treatment option within conservative care that has support within the literature. And so current recommendations within the area include activity modification and anti-inflammatory medications as primary modalities. So what about comparing operative versus non-operative treatment? So this is one paper published in the JBJS in 2019. Overall, little data exists to determine the efficacy of operative versus non-operative care. So this study was a multi-center trial consisting of concurrent randomized and observational cohorts, and they compared the effects of operative and non-operative management. The primary outcome here was the differences in mean change from baseline SRS-22 and ODI at 2 years. In the randomized group, there were 63 patients. However, 64 of these patients were non-op to operative crossover. In the observational cohort, a little bit higher patient population at 223. So their conclusions were, if a patient with ASLS is satisfied with current spine-related health, then non-operative management is advised. Improvement is, however, unlikely. Now, if the patient is not satisfied with their current spine health, then surgery is performed. So pretty broad recommendations, but I think that does kind of hint at how little we really do know about the effects of non-operative management in these patients. So indications for surgical management, I think the primary indication is pain that's unresponsive to non-operative management. Of course, if there's any onset of respiratory failure, which is rare, then that may push our hand to operate a little bit quicker. Now, if there's progressive deformity that's unacceptable to the patient due to poor cosmesis, that's also an indication. And then if the patient's asymptomatic, we still may consider surgical management if there's a large curve in a young adult or a rapidly progressing curve, then it's especially amenable to early selective fusion. And unbalanced or uncompensated deformity leading to severe postural deformity is another indication. But again, in general, it's a lot of it is based off the patient's reports, the patient's complaints, and how satisfied they are with their current state of health. The main goals of operative management, as we discussed before, the importance of sagittal balance. So restoring that sagittal balance is one of the primary goals. And of course, if they have any neural element compression, the goal here is to decompress those neural elements. Obviously, complication avoidance is a critical goal here. Oftentimes, these are big surgeries, and so it's really important to weigh the risk benefits. And for the patient, improve quality of life. I mean, that's the end goal here. So a summary would be to perform the smallest operation possible that would help relieve the patient's primary complaint with the least amount of risk. From the spinal parameter standpoint, our goals are a correction of the SVA to less than 5 centimeters, pelvic tilt less than 25 degrees, and lumbar lordosis within 10 degrees of pelvic incidence. Now, I think it's important to mention that these parameters are, I wouldn't say they are strict parameters. I mean, we have to take each patient into account, each deformity into account, and weigh the risk benefits for each case. So factors involved in decision making. So again, it all depends on the patient's complaints. So if the patient complains of primarily back pain and they have local degeneration or instability, then a short fusion would be reasonable. If they have a flexible or correctable imbalance, then a long fusion may be considered. And now if there's a stiff or uncorrectable imbalance, then a long fusion with the addition of osteotomies to help achieve that correction. If there's primarily leg pain with evidence of neural compression or stenosis, then a local decompression may be all that's needed. If there's degenerative spondylolisthesis, then local decompression with or without a fusion. And then, as I mentioned before, a rapidly progressive deformity, you may consider using a long fusion to prevent deformity occurring at either the above or below levels. So I think in general, selecting the best treatment approach is complex and requires focusing on the main reason the patient is seeking treatment. So Silva and Lenke produced this paper, which was a summary of the evaluation and management of adult degenerative scoliosis, and proposed the 6 levels of operative treatment. And the 6 levels would be decompression alone. Level 2 would be decompression, limited instrumented posterior spinal fusion, decompression and lumbar curve instrumented fusion, decompression with anterior and posterior spinal instrumented fusion, thoracic instrumentation and fusion extension, and then the last one and the most invasive would be the inclusion of osteotomies to achieve your correction. So level 1, decompression alone. So particular symptoms in patients with localized neural compression, mild scoliosis, no signs of instability or rotatory subluxation, lateral esthesis, and good sagittal balance. These are the patients that may benefit from decompression alone. And it's best if it's limited to a single spinal level. Multiple level laminectomies and foraminectomies have less predictable results. Again, here the relative indications are patients with leg pain, minimal to no back pain, a Cobb angle of less than 30 degrees, less than 2 millimeters of lateral listhesis, and normal coronal and sagittal balance. Now, it's important to note that, as I sort of mentioned before, that decompression alone can lead to deformity progression and worsening of their symptoms. So it's important to avoid decompression at the apex of the curve or at the bottom of a rigid curve. So how do these patients do when compared to decompression with or without limited fusion, basically comparing level 1 versus level 2? So Dobbs et al. Conducted a retrospective cohort study comparing decompression alone versus decompression with limited fusion in degenerative lumbar scoliosis. So their trial included patients older than 65 years old with mild degenerative scoliosis, less than 30 degrees, with stenosis. And in the decompression alone group, 37% of patients developed recurrent stenosis compared to 8% in the decompression plus limited fusion group. It's important to note that the recurrent stenosis occurred at different levels. So for the decompression only group, recurrent stenosis occurred at the level of the decompression, whereas in the fusion group, it occurred adjacent to the fusion. 75% of patients in the decompression alone group also had recurrence of symptoms compared to just 36% in the decompression plus fusion group. So they suggested that the decompression and fusion may be a more effective treatment for patients older than 65 with symptoms of stenosis. Keller et al. Reported an observational cohort study looking at MIS decompression for focal lumbar spinal stenosis in patients with and without deformity. They concluded that MIS decompression alone for leg dominant symptoms is clinically effective procedure in the majority of patients. However, when there's presence of lateral esthesis, there's a significantly higher revision rate, suggesting that limited fusion may have a role in this population specifically. So bumping up our level to decompression and lumbar curve fusion. So this is indicated when patients report symptoms of back pain associated with their spinal deformity. Typically, curves are less than 45 degrees. There may be greater than 2 millimeters of subluxation. Importantly, there needs to be lack of anterior osteophytes in the operative region to allow for correction, and again, quote unquote, reasonable coronal or sagittal imbalance. So this would include anterior spinal fusion via TLIF, which can be an important adjunct at the lower levels when fusing the lumbosacral junction specifically. Briefly, principles of level selection. So the upper instrumented vertebrae should be the neutral and stable vertebrae. Oftentimes T10 is chosen. The upper vertebrae should not be the apex of the thoracic kyphosis like T5 to T8, or the coronal curve, or the vertebrae with a kyphotic disc segment below it. Controversy does exist over where to stop distally, either stopping at L5 or S1. From what I've seen, you consider stopping at L5 if there is good bone quality, if the fractional curve is less than 15 degrees, or if the L5-S1 joint is healthy. There's healthy motion, there's no significant listhesis or rotatory subluxation. Otherwise, consider stopping at S1. So in this case, you would consider an interbody fusion L5-S1 with pelvic fixation to decrease your pseudoarthrosis risk. So level 4, anterior and posterior lumbar fusion. So this is useful in correcting lumbar hyperkyphosis and imbalance. Here we use indirect decompression via foraminal distraction. This prevents pseudoarthrosis, especially in our smokers and patients with diabetes who have an elevated risk to begin with. This would be basically a load sharing construct, so it helps prevent posterior instrumentation failure, especially in our obese patients as well. So indications for bumping this up to a level 4 would be severe spinal stenosis, back pain and deformity symptoms with a mild sagittal balance. Again, no anterior osteophytes or thoracic hyperkyphosis, and again, subluxation or no subluxation greater than 2 millimeters. So thoracic instrumentation and fusion. So this is indicated when there is significant thoracic hyperkyphosis or thoracic decompensation, and if there's a presence of global and coronal imbalance. So deformity must be flexible, however. So we assess the flexibility of deformity based off of their flexion or their dynamic radiographs. So if there's greater than 30% deformity correction on bending radiographs, this would be considered a flexible deformity and amenable to thoracic instrumentation and fusion. If it's rigid, as we'll talk about next, an osteotomy would be needed to aid in your correction. So long fusion and deformity correction, so this is better again for correction of scoliosis and restoration of lumbar lordosis. And it's best for patients whose curves are likely to progress. These are the patients with a high Cobb angle greater than 45 degrees, greater than 2 millimeters lateral listhesis, or coronal and or sagittal decompensation. The goals here in long fusion and deformity correction would be to relieve pressure on compressed nerve roots, restore sagittal balance and coronal balance, and maintain stability, and obviously achieve fusion. So level 6, this is our final level inclusion of osteotomies. So again, as I mentioned before, if the deformity is not correct, greater than 30% on bending radiographs, this we consider a rigid deformity. And so this is when osteotomies would be indicated. There's one paper that kind of outlined when we use certain osteotomies, and they looked primarily at sagittal balance, looked at type 1, type 2 sagittal balance, and then type A and B subtypes of type 2. So in type 1 sagittal balance, this was defined as globally balanced with a segmental kyphosis or flattening. In these cases, Smith P osteotomy where there's a mobile disc space would be the best treatment option. Now in type 2 sagittal balance, where there's global and segmental imbalance, we then subdivide these patients into type A and B. Type A, shoulders and pelvis are tilted in the opposite direction. And what they mentioned in this paper was that asymmetric PSO would be the best osteotomy option. Now in type B, where shoulders and pelvis are tilted in the same direction, they then kind of suggest that vertebral column resection would be the best option. So as I mentioned We sort of reviewed this a couple weeks ago when I was discussing one of our cases. So this was a paper by Dr. Schwab looking at the different osteotomies in the treatment of spinal deformities and indications, classification, and surgical planning. Briefly, grade 1, this is where there's just a resection of the a resection of the facet joint, usually just the inferior portion of the facet. And then bumping up to grade 2 would be including the superior and the inferior facet in your resection. Grade 3, we start talking about pedicle or partial body resection, either a partial wedge resection of a segment of the posterior vertebral body. Grade 4 would be that with inclusion of the disc, either typically above that vertebral body. Grade 5 would be a complete vertebrae and disc resection, and grade 6 would be multiple vertebrae and discs resected. So we talk about osteotomies, but what about anterior column realignment? So this was a paper that tried to classify the comprehensive anatomical spinal osteotomy and link it to the anterior column realignment classification. So essentially the 6 grades of anterior column realignment are grade A, which is just ALL release with a hyperlordotic cage and keeping the posterior elements intact. Grade 1 would be an ACR plus a Schwab grade 1. So this would include additional resection of the inferior facet and joint capsule. And based off this paper, I tried to include the correction that you would expect to achieve. I think in general, these numbers are variable, but for grade 1, you see about 13 degrees of correction when using a 30-degree cage. In our grade 3, this would be in our grade 2, this would be an ACR plus a Schwab grade 2. And this is where you see the additional resection of both the superior and the inferior facets. Here you'd see a little bit more correction, 25 to 30 degrees. And grade 3 would be ACR plus adjacent level 3 column osteotomy or the pedicle subtractant osteotomy. Not much data on how much grade 3 and grade 4 how much correction you achieve. They suggested about greater than 30 degrees is often seen. And then lastly, grade 5 ACR plus Schwab grade 5, which would be complete or partial removal of the vertebral body and both adjacent discs. You can see up to 40 degrees of correction here. So this was kind of a good paper, just kind of classifying the different combinations of ACR and the Schwab osteotomies. And as we need more and more correction, we kind of bump up those grades. So minimally invasive and hybrid approaches. So this was more so induced over the last decade. Typically involves a less invasive anterior, anterolateral, or transforaminal approach to the disc space. So there's less disruption to the surrounding anatomy. Interbody fusion is usually augmented by minimally invasive posterior pedicle screw instrumentation. This was initially only recommended for small flexible curves with minimal sagittal malalignment, typically SVA less than 6. But I think indications now are expanding. So in summary, adult spinal deformity, this is a wide spectrum of etiologies, presentations, and treatment options. Many studies have confirmed the importance of sagittal balance and its overall effect on the patient's quality of life. So this is a parameter that we oftentimes focus on, especially when we talk about our operative planning. So our operative sagittal alignment for deformity includes a T1 spinopelvic angle less than 0 degrees, an SVA of less than 5 millimeters, pelvic tilt less than 20, and our PI and lumbar lordosis match within 9 degrees. Physical exam, history, and preoperative planning are crucial to our success. I don't think every patient is the same. This is not a cookie cutter. You have to really, really plan your operation based off the patient's complaints and their individual deformities. And the goals are, as I discussed previously, are based off the presenting symptomatology of the patient. Thanks you all for listening. Happy to take any questions now.
Great job, Tommy. Big topic. Hard to distill into 30 minutes, but you did a great job.
Thank you.
Totally agree, and the picture at the end makes everything amazing.
I thought you'd like that, sir. That's why I included it.
That's good. go. Let's go. Well, maybe not after this weekend, but
not our year this year. Maybe next year.
any questions from the folks on the call?
Tommy, this is there was great talk, very precise, and it's going to be. It was very difficult to, as Bob said, to put it in 30 minutes. One thing that I think there is no question, the sagittal imbalance was ignored in the past, and that study that you mentioned on Stu Weinstein, we actually tried to get some sagittal correction from him, and there was no X-rays taken at the time. Those all long-term results were all based on AP X-rays or PA X-rays. So there was no attention to the sagittal balance, and I think it's a great change in understanding of adult deformity. However, sometimes the pendulum swings a lot, and we sometimes forget about coronal imbalance. And I think some of the issues with coronal imbalance is hard to compensate, because some of the sagittal imbalance we can compensate by other areas of the spine. So hopefully that is not forgotten. It's probably not as important, but it is something that we need always to remember to make sure that the coronal imbalance is that's why you do the T thing and the OR and other things that you do. So just wanted to bring that up. Great talk. Thank you.
Thank you.